بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello, my dear brothers. I will talk today about the cornea. The cornea is the anterior third of the outer coat of the eye, and it's responsible for a lot of functions. Let's see. First thing to explain is the anatomy of the cornea. The cornea is consisting of 5 layers, which is increased 1 layer after 2013, after discovering of the pre-decimate layer by the Heminder duo, which is called the dual layer. So it became 6 layers instead of 5. Let's count the layers together. The first layer is the epithelium. The second layer is the Bowman's layer. The third one is the stroma, the corneal stroma, which is divided into anterior and posterior stroma. Then pre-decimate layer, then decimate membrane, and finally the endothelial cell layer, or the corneal endothelium. So these are 5 layers, and after adding the pre-decimate layer, which is Dewey's layer, which is called Dewey's layer, they are now 6 layers. The epithelium consists of 5 to 7 layers, starting with the basal cells, which is long cuboidal cells, then another layers of cuboidal cells, but with different length and shape, not like the basal and not like the surface layers. And then on the top of the epithelium, there is stratified squamous non-keratinized layers. They are 5 to 7 layers. And they are non-keratinized because it's very important for the cornea to be transparent. So they are keeping the corneal surface regular and transparent at the same time to allow the main function of the cornea, which is refraction of the light and vision. So the health of this epithelium is very important for the transparency of the cornea and the refraction of the light as well. The Bowman's layer is one homogeneous layer, which is very tough and strong sheet of homogeneous collagen with no fibrils. It's very important for keeping the elasticity and contour of the cornea. So the loss of Bowman's layer after trauma or after laser ablation will affect the corneal strength and the corneal biomechanics as well. The anterior stroma and the posterior stroma forming the stroma proper. The anterior stroma arrangement of the fibrils or the collagen lamellae is different than the posterior stroma, and they are parallelly arranged in a very regular pattern and fashion to allow the passage of light without a lot of reflections and scattering. And this property is very important for transparency of the cornea. And I told you that the transparency means that the light will pass without reflection, but in corneal collagen lamellae, there is around 10% reflection of light or scattering of light. This 10% scattering of light, it's of a goal, or it's for an aim. Subhanallah al-Azim, the 10% reflection of light will help you to see the cornea on examination, because the air is transparent. There is 100% passage of light with no reflection. But in the cornea, there is 90% passage of light and 10% scattering or reflection of this light to see the cornea itself. Otherwise, you will not be able to see the cornea on examination, which is very problematic on diagnosis and on examination of the cornea. Finally, the pre-decimate layer, which is part of the posterior corneal stroma, and finally the decimate membrane, which is the same like the Bowman's membrane. It's one sheet of collagen of a different pattern, different features, and different type and power. It can resist. It can resist the penetration, and it can resist the weights as well. It's around 4 to 8 micrometer thickness, but it's very strong sheet or membrane. Just beneath it, there is the endothelial cell layer, which is a single layer of hexagonal mosaic cells with a very important function, which is the active pump of these fluids and electrolytes between the cornea and the aqueous, to and fro movement of the electrolytes and the fluids. Otherwise, if there is any problem with the endothelial cells, the active pump function will be disturbed, leading to accumulation of fluids in the corneal stroma, leading what's called corneal edema, which will interfere the corneal transparency, and hence the patient won't be able to see clearly. So it's one of the causes of blood or corneal blindness. Finally, the endothelial cell layer, our endothelial cell count is around 3,000 cells per cubic millimeter. It's between 2,000 and 4,000, with an average of 3,000, but should be more than 2,000. Less than 2,000, it's not healthy one. I told you about the corneal stroma and the corneal endothelium, and look here, the anterior stromal rigidity is important in maintaining the corneal curvature, and the posterior stroma. Look here at the photo, the anterior stroma arrangement of lamella is different than the posteriors. So the dissection in the posterior stroma is much easier than the anterior because it's not with the same pattern of arrangement. And down, this is the hexagonal appearance and the mosaic appearance of the endothelial cell layer. Response to injury, the cornea has epithelium, stroma, and the endothelium. So on epithelial injury, migrating sheet of epithelial leading cells are pulling the epithelial sheet as it migrates. So the healing starts from the periphery towards the center, which is called centripetal. Mitosis begins to restore the epithelial cells after 24 to 30 hours from injury, so the epithelial scratch or even epithelial removal during surgery will be compensated when the healing of this epithelium starts after 1 or 2 days from the removal. During surgery, epithelial injury is not rare, but is generally mechanical and can be treated, so no worry on epithelial injury. About stromal injury, separation of stroma from descemet membrane or Bowman's membrane activates strong wound healing, which consists of 3 stages, which is 3 R's: repair, regeneration, and remodeling. Repair, to repair the lost part of the tissue; regeneration, formation and resuming the normal pattern and normal shape and normal count of cells; and remodeling to acquire its original shape, distribution, and thickness to help the normal function of the tissue. Interplay of CKGF, which is growth factors, and cytokines and chemokines occur in healing process without vascular component. They are nourished with the diffusion from the limbs. There is no blood vessels, so presence of blood vessels, which is called corneal vascularization, is an abnormal response to the injury, which will happen in the unusual cases or the severe cases of injury, like in the corneal ulcers. Activation and migration of stromal keratinocytes are the first response to stromal injury occurs within hours, which have fibroblast-like activity. So the fibroblasts, which are responsible for the healing process, especially the secondary um, healing or secondary regeneration, is responsible for the scar formation, but the keratocytes are the fibroblast of the cornea. Okay, within 1 to 2 weeks, myofibroblast involved in stromal remodeling, while healing process takes months or years to complete, and sometimes reduction of corneal clarity occur due to disorganization of the extracellular matrix secreted by the myofibroblast and decrease of the corneal crystallines in these cells, leading to stromal fibrosis associated with corneal opacity. And so this is the mechanism of the corneal opacity formation. What about the descemet and the endothelial injury? Descemet detachment occurs in 0.5% of cataract surgeries. So descemet injury means descemet detachment, which vary. This detachment is variable. So it varies from small localized to large detachment, which may need placement of air bubble in anterior chamber to hold against the posterior cornea. I'm injecting air if I sensed or noticed any detachment of the descemet layer at the end of the surgery, because the air bubble in the anterior chamber will help restoring or repositioning of the detached part of the descemet to the back of the cornea again. So it's very important to consider the air bubble at the end of the cataract surgery. Endothelial injury may result from full thickness injuries, focal distortion of endothelium, as in cataract surgery, and endothelium trauma by high fluid turbulence during phacoemulsification. So these are the variable causes and the common causes of endothelial injury during the surgery, and hence it's at the level of the undergraduate. I don't like to deepen the full details about this issue. I'm trying to simplify it, not to be complicated. What about physiology of the cornea? Simply, it's transparent, so transparency is important for the vision and refraction of light. It's convex, so it's power around 42 to 45 with an average of 43 diopter convex lens. So it's prolate and a spheric surface to help refraction of the light with decrease with a very minimal degree of high order aberrations. So it's a main refracting surface of the eye. So the physiological the physiology of the cornea is protection of the globe or the internal structure, because it's elastic, it absorbs a lot of traumas. Also, it's transparent and convex, prolate and spheric surface. So finally, the physiology is protection and vision after that. Resuming our presentation about the physiology of the cornea, the viscosity and the elasticity is one. Both are the features of the corneal tissues, and they are responsible for the corneal biomechanics. Biomechanics means that the cornea is elastic tissue, so it will regain its shape after indentation, and the viscous, it's moving all over, all around, and comes again to its position. So these features are very important to know about the corneal biomechanics, which is, this is the normal cornea. This is normal a picture for the normal cornea, and this is a side cut for a side view for the cornea, which is prolate as you see on both in both photos. Viscoelasticity is responsible for the tensile strength of the cornea. Normally, the corneal collagens are cross-linked. Cross-linked means that they are intermingled together and they are attached to each other in the normal cornea with the normal collagen and the normal collagen bonds. While in the abnormal cornea, there is problem with the cross-linking with weakness of the cornea. And this is the measurement of the intraocular pressure using the Goldman applanation. So the corneal hysteresis means the corneal elasticity, the CH, and the CRF is the corneal rigidity factor, which means the rigidity and the corneal stiffness of the cornea, and IOP, which is the intraocular pressure. Excuse me, CRF means the corneal resistance factor, not rigidity. Corneal resistance factor, which is explaining or expressing the stiffness of the cornea, which will be expressed in millimeter mercury degrees. Like intraocular pressure normally is from 10 to 21 millimeter of mercury. So according to the elasticity and the corneal resistance, the IOP will be either normal, higher than normal, or lower than normal. And this is the applanation, this is the other mean of IOP measurements, which is the air puff, where the jet of air leads to indentation of the cornea. So the amount of indentation of the cornea, which is concavity, the convex surface becomes concave, as you see in the photo on the right and the left side. So the amount of concavity or the amount of indentation will be expressed as the amount or the value of the intraocular pressure. And this is the Carvis standard, and this is the printout showing here. If you look, you will find that the intraocular pressure is 15. The same corneal hysteresis is one of the factors which is responsible for the corneal response to the traumas and indentation, and also it's important in the field of refractive surgery. And this is the scientist who invented the ORA, which is the ocular response analyzer, and brought the concept of hysteresis, which means lagging behind. And these are values for the normal and abnormal without surgery and after surgery. Thank you so much for the first part, and please wait for the second part, which will be about the corneal ulcer. Thank you so much.